Hello everyone, welcome. I'm Dee Eaton, Senior Clinical Editor at Nursing Times. Welcome all, it's a pleasure to be here again chairing the next webinar of the Nursing Times Clinical Skills event series, and a very warm welcome to Liz Kerr, retired adult nurse and chair of the National Pensioners Convention LGBTQI+ working group and LGBTQI+ advisor for NPC RCN Retired Members Network. Today, Liz will present on indwelling urinary catheterisation of patients with specific needs, such as patients with congenital conditions, transgender people undergoing gender-affirming surgery, and FGM victims. At the end of the presentation, Liz will take questions from the audience, so I suggest you note any questions you may have for her. And now it's over to Liz.
Good afternoon, everybody. Thank you, Denise, for that welcome. Yes, I'm Liz. This is me. I'm a retired nurse, and I've been kindly invited by Nursing Times to discuss some of the non-practical aspects surrounding indwelling catheter insertion. That's just some of my educational background and obviously some of my roles that I've had, and I still do work voluntarily for the NPC. So before I go on to my next slide, I'm just going to tell you a little bit more about my clinical background. My career spanned 30 years over 4 decades, and I've worked in pretty much every aspect of health and social care you can think of. I've worked in the NHS, the private sector, social care, been in the charity sector, currently volunteer sector, and I've held a number of positions from band 1 domestic assistant through to band 7 site clinical manager. And from a clinical perspective, I've had multiple specialties as wide ranging as ITU, palliative, infection control, renal, elderly frailty. And on top of that, I don't know whether it's fortunate or cursed to be a member of the on-call emergency bleep team when I was site coordinator. And that was for stroke thrombolysis, cardiac thrombolysis, obviously cardiac arrest and arrest calls, emergency calls, and also the trauma team. So from a background perspective, wealth of knowledge, and my current work and my passion is working on all things EDI related, which is how I ended up with the position of chair at the NPC LGBTQ+ working group. So the following slides, please don't think they're designed to add paperwork or red tape or any other thing to your clinical work. They're meant to form the backbone of little backstop things of an automatic conscious thought process of things that you can be ticking off in your head even before you get to the point of having to put a catheter in someone, before you're at the bedside. So some of these are obviously your code of conduct. I used to literally live and breathe the code of conduct, because I knew at a basic level that if you embrace that completely, you're never going to go far wrong with your patient interactions and your colleague interactions, because it's all in there about dignity, respect, just the whole gamut of the range of things that you should be thinking about regarding your standards of care. And for catheterisation especially, nice to have their guidelines as well. That would be on top of any local policies or procedures you've got. Obviously, I put in UK laws, European laws. It's illegal in this country to perform female genital mutilation, and it is a human rights violation, and obviously European Court on Human Rights, to have that imposed on women and young girls against their will, often from as young as 5 years old. Now, you might think health and safety manual handling, what's that got to do with putting a catheter in somebody? And the reason I put in the LIGHT acronym, which I hope most clinical people will understand, is that if you've got a bariatric patient where it might take more than just you or you and a colleague to put a catheter in somebody, because if they are bariatric, that then becomes a time management issue and a personal management issue about how many people do you need in one place at one time. So again, it's there as a thought. Do you need to think about those considerations? Now, I shouldn't have to put in communication, confidentiality, and consent, but it's important because our body language doesn't always mirror what we say. And it's very hard sometimes when patients see a discrepancy. And often how I found a way around that was just being very warm and smiley and happy and engaging, and to avoid any misintentioned getting people's gender pronouns wrong or their names wrong. It would simply be, hello, my name's Liz. Can I just check your records? How would you like to be addressed? What's your preferred name? Because then you don't have to ask them any personal questions about gender preferences or gender markers. They will then just tell you what you need to know. And it's a huge thing because it's not just insulting and degrading to trans people, but just in the general population, it's a dignified way of dealing with people. Now, hopefully the Houdini catheter tool is a national thing, but if it's not, it's a tool available to nurses that tries and helps establish, do you actually need to be putting a catheter in somebody? And if you can't answer all the Houdini questions, like, is it hematuria? Is it an obstruction? Is it a urology problem? Is it input-output monitoring? Is it skin damage prevention? If you can't say yes to some of those questions, why are you doing it just by rote? Why haven't you stopped to think, have I got a reason for this? Now, talking about EDI, obviously, you've got to think along the terms of your activities of daily living, Roper-Logan journey, impact on body image, masculinity, femininity, and certainly if you're talking about putting long-term catheters in or changing a long-term catheter, the impact on their sexuality and their sexual health and well-being. So again, that's another not necessarily clinical aspect that you need to consider, but it should be part of your holistic view of looking after your patients and finding the time to talk to them if they have got concerns, because it's not nice having tubes sticking out of you. Colostomy bags, ileostomy bags, urine bags, not exactly high fashion. I'm going to talk as well about abnormal physical anatomy, whether that be birth defects, whether it's somebody's had gender affirming surgery, or whether it's because of female genitalia mutilation. Because don't forget, the first point of contact for some of these people might be at the first point they have to disclose that they've had gender surgery or that they've had FGM done to them. So it's being in that moment and providing the time and reassurance to your patients that you're there as an individual for them and allow them that time to open up. Because you could be the first, and then that sets the standards, the bar for every other interaction that follows. It shouldn't have to repeat safeguarding both adolescents and adults. FGM can occur in young girls as early as 5 years of age, and it's a trauma that will live with them for the rest of their lives. Psychological, emotional trauma. And even for gender patients that have gender affirming surgery, they can be in a very vulnerable position emotionally and psychologically. It's a huge thing to commit to and go through the process of transitioning and all that goes with that. So they can be in a very vulnerable position. And the last on there is just two other obvious examples of things that you should be aware of, certainly if you've got a medical history, is have they had any other surgeries? Have they had cancer? is there any damage or scar tissue from radiation therapy? So those are just some of the things that really should be in the back of your mind that you're ticking off. And it doesn't have to be a long 10-minute question. It's just that A, B, C, D, E, just like you do with your CPR. Just make sure you're dotting off those different things as a conscious act. Okay, next slide. So this is now getting down to general rule of thumb for gender patients. And you should treat as they present. So if they look like they're female and they identify as female, they should be treated in a female space. And they don't need a gender recognition certificate to do that. And the same goes for obviously the male counterparts, that is a present as male, treat as male. The only problem that would occur is if you've got somebody that looks male but identifies as female, you can't just put them in a single sex space because they identify as female. So you've got to have a difficult conversation about where are you going to put them. It would be a side room or somewhere where you've got a mixed clinical bay. Somewhere like CDU is a good example, where on clinical grounds you might have a mixed area, or renal dialysis, you might have a mixed area. But when we talk about trans men and trans women, that's just some of the language that's used within the LGBTQ plus community. And certainly the abbreviations of AFAB and AMAB might be new. Well, that's just to help differentiate, not just for trans people, but non-binary as well, that they might not necessarily be identifying as a gender they were assigned at birth. But in considering trans men, there's not going to be a prostate. So if you're trying to catheterize trans man, there's not going to be that resistance that you would normally expect. And if you're not aware that obviously that might be a reason for it, it might leave you a bit stumped as to why there wasn't any resistance from the prostate. Obviously, trans man has a urethra stretched. So there is scar tissue in, could be urethral strictures. It makes it a lot easier to damage and get fistula formation with a catheter. Now, on the flip side, if we're talking about a trans woman, they still have got the prostate present. So you might be expecting a straightforward catheterization, and then you've got the issue of getting past the prostate. Obviously, if it's enlarged, it might make it very difficult catheterization. And if you don't know that there's gender surgery, what are you going to put that down to? In female gender surgery, your anatomical physical markers might be slightly not in the same points as you would expect to see them. And again, that's down to how the tissues heal with scar tissue. And although they don't have their urethra stretched, they still might be at the same risk of urethral strictures and fistula development. So yeah, just simple things, but things that you can easily just hold in the back of your mind to be prepared as a first point of call, to give you that little bit of confidence that I can deal with it if people talk about these things. Okay, next, please. Right, this is the topic that might be a little bit uncomfortable for some, and I do apologise, but it's conversations, just like cancer, death, dying, mental health, money troubles. You are going to have uncomfortable conversations as nurses, and we are there more than anybody else. So some female genetic abnormalities that you might not be aware of is urogenital sinus. It's where there is no external urethral opening, but it actually exits into the vaginal cavity. So you're not going to have that external marker to try and catheterize. Cloaca, struggled pronouncing that. This is where all three, urethra, vagina, and rectum, share a common opening. So again, you wouldn't have that external marker. Now, talking about female genital mutilation or genital cutting, as it's otherwise referred to, it is an issue to be aware of. We've got a growing migrant population, we've got a growing minority population, and obviously the numbers involved in that are quite big. The document I've used is the WHO International Care of Females and Girls that have had gender mutilation done to them, and the address is there to look that up, and it's a long read but a good read, and I've tried to summarize these. Type 1 is just a partial or total removal of the clitoral glands in the prepuce, which is the little area of the skin just above where the clitoris lies. Type 2 is a bit more advanced, where there's partial or total removal of both the clitoral glands and the labia minora, and plus or minus the labia majora. Type 3 is where there is some kind of narrowing of the vaginal opening, normally by cutting and repositioning the skin and sewing to create a cover. And again, that might involve both the labia minora and majora, and with or without excision of the clitoris. And type 4 would be any other harmful procedure that has no medical benefit. Piercing of the clitoris, scraping, cauterizing. Now, some of those sound really horrible, and I'll touch on those a bit later because I'm going to do a bit of a myth-busting thing for you about FGM. So can I have the next slide, please, Denise? So this is purely a simple diagrammatic illustration of those types of female genital mutilation, and it shows the areas that would obviously be involved of cutting and of stitching, and the M1 is just anything else that would normally alter those anatomical structures that you would expect to see in a young female and obviously an adult woman. So slide 5, I think that's the visual illustration. So then the next one, please, Denise. These are some of the myth-busting facts. They're not all of them, and I would suggest reading that WHO document because there's way more in there than I could condense into one afternoon of talking about these things. But these are things you've got to remember, that this is a cultural, historical normality in some parts of the world, in Africa, in Asia, and it's seen as a rite of passage in some respects. But uncut girls can still find them married partners. I mean, why wouldn't they? It's just like anything else. It wouldn't stop them being able to do that if they haven't had it done, although it is seen as making them more desirable, more fertile. But there's not even a religious overtone for doing FGM. Point 2 is exactly that. It's not a religious mandate. Yes, cultures have different rites of passage, and not all of them include doing things that is traumatic event that someone has got to live with for the rest of their life, and will not only necessarily affect them, but their partners, their husbands. Because the next one is, it can cause long-lasting pain and damage to the female, but it can also be painful for the male partner as well. So if you imagine a narrow, restricted opening that hasn't got any kind of elasticity to it at all, and don't think that FGM will actually promote any kind of sexuality or have control over a woman being faithful or faithfulness. It doesn't. Actually, quite the contrary. Why possibly would you want to stay with somebody that's forced this upon you at a young age, and such a horrible thing to have forced on you? Why would you necessarily want to be with them and do anything with them? I don't know. I'm not from that culture, so I can't comment, but we should be aware that they're normal. That's what they live by. That's their belief code. That's their values. And as nurses, we've got to respect that, even if we don't understand it ourselves. The next one, having FGM performed by a professional person rather than just someone within the community. Even with skilled female genital mutilation, it can still cause long-term physical damage, yet alone the emotional and the psychological scarring that goes alongside that. And it is a form of trauma and PTSD. One event can dictate the rest of their lives in many respects and is always there. So it is huge for these people. And if you're the one they're opening up to, you've really got to be there in the moment. Make that extra smile in a few seconds. Do you need to talk something over? Make your body language reiterate what you're saying. Yeah, a woman who is uncut cannot become pregnant. Well, yeah, that's clearly false. Well, we know that from a medical perspective, but obviously we're talking about some cultural traditions and maybe communities that don't have the benefit of that knowledge, that scientific knowledge. If a woman is deinfibulated, a baby might fall out during pregnancy. Deinfibulation is when you physically try and undo the female genital mutilation that was done in the first place. Which again is another not nice thing to go through. But it might be that somebody wants to have that done, go back to a more normal looking, potentially normal looking exterior, anyway, exterior genital looks. And FGM has health benefits for a baby. Absolutely no way. There's no medical benefits for the mother. And in fact, actually, if you think about it, the converse is probably true. Because if you're restricting what is the vaginal opening that a baby's born through anyway, which dilates in pregnancy, if you've then curtailed that, not only actually going to make problems for the birth, not actually make it any easier for the baby. So, yes, some of those myths and facts, then they are worth just noting up there. And it doesn't matter if it's only 1, 2, half a dozen of these things that you remember. It's just that's one step forward for the next time to equip you with skills for dealing with things that are uncomfortable. Okay, so that means I'm coming up on to slide 7, please. But before I explain some of these, please don't relate FGM to male circumcision. There are religious doctorates for male circumcision, and it does actually provide health benefits to the male. So it's 2 completely different arguments. So we've talked about female anatomy. I'm now going to run through male anatomy. The first one is, as it says there, where the urethral opening is not where you would normally expect it to be. And I'll talk a bit more on that in a minute after I've done the other couple, because it's one that you might actually come across. It's not just one of those you should know in case you do, but one that is a practical thing to do. Cryptorchidism, mouthful. That's where either one or both of the testes don't descend properly. And although externally that might not alter the urethra from the penile tip down to the base of the penis, there might well be deformity inside because of the underlying tissues. Poon belly, oh, what a lovely name. It's a genetic defect which causes an extra obstruction at the neck of the bladder. So if you think of catheterizing a male, you've got the pressure going through the prostate gland, and then you've got a second double pressure of trying to get into the neck of the bladder. It can be a double problem, and that's why you might feel a double kind of resistance. And the other one is posterior urethral valve disorder. This is where there's just extra membranes right at the back of the urethra, just prior to where the prostate and the bladder neck will be. And it might mean that you've then got an extended point of resistance trying to push through into the bladder. So rather than just a one quick push through, it might be a long, slow push through. And again, I've listed a reference there in case anybody wants to do a bit more reading, because there are others, but those are some of the more common ones that you might be expected to see in practice. Now, I said about hypospadias. The reason I knew about this before today was I'd actually come across it in practice. I'd been asked to catheterize a male, and I'd gone and I tried, and first time I couldn't get more than about not even half an inch of the catheter tip down the penis. So I knew there was something clearly wrong, didn't know what it was. So got the medical doctor up, and the medical doctor then took 3 attempts over 15 minutes and was literally, I'm no joking, trying to ram it down. And I'm going to say, I think you've got a problem. I think you need to stop. No, I know what I'm doing. And on the 3rd attempt, I just went, stop. You've already done 2. You're now attempting a 3rd with clearly trauma now, because the poor gentleman was bleeding. And he said, oh, well, I suppose I'll have to go and speak to urology. And I didn't wait for them to do that and then wait for urology to turn up. I just rang urology, and the very nice urology doctor came down, and I explained what the problem was. And they just went, I'm not going to explain it. I'm going to do it and show you and tell you as I'm going. I'm sort of like, okay. Obviously they got set up, and straight away it was just lifted up the penis and looked down the length of the penile shaft to just where the fold is with the scrotum. And there was a tiny, tiny, tiny little puckering, and literally just straight in, 2 seconds and done. And they went, that's hypospadias. You need to be aware that men have these openings that aren't where they should be. And I went, all right, okay, that's one for the knowledge banks for future reference. So sometimes it might be once in a lifetime, but you've got that knowledge there to pass on to others. And this is all about sharing the knowledge that we should have available to us, and knowing not just our level and where we're at, and being big enough and professional enough to say, I've had 2 goes, I'm going to pass it on. It's who do you go to? What's your escalation process? Who can you trust to get something done? And the last one, please, Denise. Now, this is just to do with ambiguous genitalia, intersex people, those that through quirks of birth have chromosomal defects that affect the development of their exterior genital markers. And it's a scale named after a Quigley doctor, and the reference is there. And it just shows the linear from one side fully masculine to one side fully feminine, and the stages in between that you might come across. And again, the reason for including this and talking about the law and confidentiality and GDPR is, if people have faith in you as a professional person, that they might open up to you And I say that because, again, I was very fortunate, and I count myself blessed that a patient did do that one night. This patient had been in and out for years with other medical issues, and I'd just been the happy, jovial me and warm smiles and sort of like just making sure that I was doing a tiny little bit extra to make the patient feel like an individual. I just went, "Have you got 2 minutes?" I thought, "Yeah, well, I'm not busy, so I can part what I'm doing. I'm in the middle of a drug round, but it doesn't matter." And just went, "Do you seem the kind of person I can talk to?" And I went, "Oh, maybe you need to talk to me." I've never told anybody this before, and I'm not sure I want anybody else to know, because I'm still struggling with it. And I went, "Oh, whatever it is, I'm not here to judge. I'm here as a nurse to support you in any way I can. And as long as you're not going to tell me you're going to blow up the Houses of Parliament, whatever you say to me is confidential." I went, "I've been assigned male at birth for all my life, yet I'm intersex." I went, "Okay," sort of like deadpan, no reaction, total professional. And I went, "Okay, and this is relevant. Why?" Because I don't feel like that on the inside. And I finally got to a point where I feel I haven't been able to actually say that to anybody. I went, "And this is taking you how long to get to that point?" And it was, I don't know, 30 odd years. "So for all that time, you've not felt able to open up to anybody?" I went, "No." I went, "Well, that's because sometimes it takes a long time to get to the point where we can share something that we think is so personal." And they were like a different person from that point on. And the hospital admissions started dropping off, and some of the issues they were coming in kind of like resolved. And it was just, to me, a clear sense of, I wonder how much mind and body are linked, and how much do we neglect the whole person, the holistic person, when we're presented with physical, practical challenges when we're caring for people. And the answer is, obviously, they are integrally entwined, and we can't really sort one out without sorting out the other. And that is the same for female genital mutilation and transgender people. There are things that are lifelong issues that they've maybe had to battle with. And it's a growing population, migrant population, the LGBTQ population. 20% of Gen Z are openly LGBTQ+, which means it's a portion of population that you can't ignore and you should know about. And that's huge in terms of thinking about your clinical numbers for, say, type 1 diabetes, a couple of million. Well, 20% of the population is, well, whatever that is. I don't know, few hundred, few million, tens of millions. I don't know. So yeah, it's all these have been there as quick points of reference to hopefully give you a starting point. Even if it's only a singular starting point, because what you will probably hopefully find in practice, certainly those that are maybe more junior, but not necessarily older within your practice, is that once you get over one hurdle in one area, you can often transfer those skills across to other areas within your practice. And it makes life easier to deal with challenging circumstances, challenging patients, challenging complications, because you've already prepared yourself by doing that little bit of extra homework and just having that on tap. You can't remember everything. Nobody expects you to remember everything. Well, it's a question of having a point to start. And this comes back to the whole debate about dignity and respect and treating the whole person. I often used to think about Jehovah's Witnesses. I knew that was a thing, and I knew it was a belief system, and I knew it didn't involve having blood products. Past that, I just couldn't wrap my head around it. but I knew I didn't have to, unless I came across a patient that was Jehovah's Witness. All I had to do was respect that that was a thing, and that it had my respect and dignity for being a thing. So hopefully there's been a few things in there that are new to people and that will give some people pause of thought, and maybe just help some when you have those other awkward situations to deal with, when you've got the patient that's, it's not you, it's the system they're riling against. And these patients are in vulnerable minorities. They don't often have good interactions with the health system, with social care services. So to be that beacon of light for them, it's a godsend in many ways, for them to be able to start their own journeys of being more open about them. And it's just a credit to you as individuals, professionals, that you can do that. So that is about it for me. I think I've done that a little bit quicker than I was hoping, but I'm hoping there is obviously enough room for a full question and answer, and that there's some good things to actually take on board from that. So thank you very much, Denise, for being my very able assistant.
Thank you so much, Liz. That was incredibly thought-provoking presentation. Really, really enlightening. Thank you. I appreciate that. We're now going to open the session to the audience. So hopefully there'll be lots of questions that you can post in your swap card that we'll get through. I'll try to get through as many as I can, but bear with me if we run out of time, but I'll try. And could I just ask you one thing, Liz, and this might be so difficult to answer.
No.
Just if there was only one piece of advice you could offer for nurses undertaking a procedure on patients with specific needs, what would that be?
One piece of advice for any specific need, yes, not just catheterisation.
Yeah, because I can make an assumption based on your presentation, but I don't want to.
Just have the belief that no matter what, you're there to help, and just have that self-belief that you can do something special. And it might be a trivial something, but it's special. And the difference it will make to other people, patients and colleagues alike, you would be amazed at just how much it means when there is just something that makes it special, individual, that you know people are seeing and hearing you and treating you as an individual person. So that's probably the biggest one, is just have faith, back yourself.
Yeah, because it's really interesting, one of the things you said about the consideration before you've even reached the bedside.
Yeah.
You know, that's the number of people involved in a process. Just that's, I think, a great piece of advice, actually, really good. I'm not sure how many nurses would, certainly when they're starting out, would even think for that to be a consideration. What do, apart from the equipment, what staff do I need,
Yeah.
So it's great. So we've got some questions coming in. Natasha says, could we expand on the Houdini acronym?
Right. Houdini, oh my God, this is going to test my brains. Right, it stands for hematuria, obstruction, urological problems, the deep ulcers, immobility, input-output monitoring, and I can't think what the N stands for. I can't remember. Pass. It's a long time since I've had to use it, so but it's in an acronym to help, and as I say, it's a tool you can look up, and it gives you the basis of, do you actually need to put a catheter in? And if it's just for incontinence, the answer is no, just dead no. And that should give you at any stage the ability to say to senior people, no, what reason have I got to do it? Because you've got to remember that you are individual people. You are responsible and accountable for not only your actions, but your inactions. And if you can't say, why am I doing it? And have a good question to yourself, then it's down to you, and the book stops with you. So I hope that helps regards to Houdini.
And it was that accountability that you explained as well when you were talking about Papspadius in that patient, just to say stop. You've attempted it twice, you're attempting a third time, the patient is distressed. It's clear, you know, it's remembering
it's knowing those levels. And even for me, not knowing what was wrong, it's just that acknowledgement, it's wrong. You don't have to know what's wrong. We're not there to diagnose problems. We're there to kind of like fix them, but we don't do diagnosis as such. But we should know what system is wrong. And I knew enough to know that it was clearly a urology problem because there was an issue with plumbing. So you don't have to have years of experience to have that kind of light bulb moment and go, it's not right. I'm not doing this. I'm stopping, or I'm elevating.
So Deirdre says actually that, linking on to that, so Deirdre asks, should nurses always refer a patient to urology if they find they've had FGM? What would your recommendation be?
Again, it's probably a conversation that you might want to have. It might impede the ability to catheter someone, female young lady that's had FGM, but it's only the external markers, not the actual urethra going into the bladder. So it's only if you struggle to find the exterior markers. If you think there's liable to be internal scar tissue, then urology is a sensible next stop. And certainly if you don't feel confident, and this comes down to that confidence, competency, have I got enough knowledge and enough competence to feel I can deal with this? And if you can legitimately say, I've never dealt with FGM before, I don't feel equipped to physically catheterize a patient with FGM, I think you've got every right, certainly as a nursing professional, to say, I haven't got that experience. Can somebody else show me what to do and how to go about it, so that next time I can do it and then pass that knowledge on?
So Mihaela quite helpfully says on the Houdini acronym, nursing care and immobility for the last two letters of the acronym. Thank you, Mihaela.
All the nursing issues,
Kathy says, I have worked extensively in the Middle East where lots of migrant workers from North Africa live. The practice of stage 3 is rife and girls are taken by their mothers at very early age to their village in their country, and the procedure is done in a hut. Quite worrying, really, evidence of this. And we have another question from
Religious
Michael,
mandate.
Earlier said, I thought evidence suggests that FGM has a strong cultural mandate and religion is part of a culture.
Well, you can argue that religion and culture are intertwined. Yes, they are. And as I said, it's predominantly a cultural issue, as in a passage into womanhood, a rite of passage. Well, there's actually no written religious overtones for that, unlike, as I said, for male circumcision, which is part of, it's Jewish, isn't it? It's Jewish religion that males are circumcised. Then there's no kind of like overarching religious doctrine that would advocate for female genital mutilation. But you're right, it's deeply ingrained, and it's hard to differentiate those out if you don't understand the difference.
Despoina makes a good comment. I think it's a comment rather than a question about this would be nice to have it taught in uni as well. I would definitely recommend it. So is it not touched upon at all during nurse training?
I would have the same answer as a lot of the other work I would do. Sadly, there's gaps in the syllabuses for not just nursing and healthcare, but other professions. And I'm talking about physiotherapy, occupational therapy, medical. There are aspects in the curriculum that just aren't taught. Whether they should be or not is a different matter, but it's a question of balance, and where to draw the line is something that is likely to cross your line as part of your working career, and what is just likely to be you're never going to see it in practice. Is it that really rare tropical disease that one person in sort of like 100 million gets, which nobody's going to expect anybody but an expert to know? Or is it that you've got a growing trans population? And if it's 2%, 3%, 4%, whatever the population, that figure then outstrips those with respiratory problems. I think it's what, 1.8 million have some form of COPD, asthma type respiratory problems. So if you're talking about 2% population is transgender, then that is more than 1.8 million with respiratory problems. But we don't teach about gender issues, but we do about respiratory issues. So it is, and I think some of it comes down to how lucky you are with the mentors you get and the placements you get and the access to extra support and resources, and whether you've got forward-thinking, proactive people. And that's what I said at the beginning. It's not a red tape exercise. It's not creating extra work. It's a proactive, conscious thought process where you are trying to learn as many things about as many things as you can without overcrowding your brain of what do I need to be prepared for, so that you are prepared for. That's why you have your annual CPR training. Is in the unlikely event that you have to deal with it, or you deal with it on a daily basis, it doesn't matter. You still do it because the likelihood is that at some point you're going to have to do it. And the same argument is for any other minutiae, very, very targeted, specific training for anybody. But yeah, you could argue for a lot of things to be put into curriculums.
Yeah, I can see Dee is noted here that actually it is taught. We teach clinical skills in uni, and we do cover all of these issues. We teach FGM to mental health students at the University of Derby. So well done, the University of Derby.
Yeah.
And
Again,
then
mental health, it's because of the long-lasting psychological, emotional trauma value that lives with them. It is a mental health issue.
Yeah.
On the back of a physical problem.
Adil says FGM is not a well-known practice. Oh, sorry, is not a well-known practice in countries like Pakistan, India, Bangladesh. Do you have knowledge of such practices in these countries?
Again, I don't. As I said, it's predominantly more in the African continent, but there are places throughout Asia that do incorporate that. And it might be just a regional thing, or even down to almost clan-like regions where it might just be that it's practiced not as something that is a country-based thing. But no, I do not know the in-depth views on that. What I would say is that it might well, that information might well be in the WHO book that I talked about and I gave you the reference for. And the reference list at the back of that care book is like ad infinitum. So again, it's another one of those, where do you start and expand on your knowledge, and how much do you want to learn on top of what you already know as a baseline?
Yeah, yeah. Kelly makes the point that as a uni student, they are taught about FGM, but more with a view on reporting and safeguarding, not so much on how it affects common nursing interventions. So,
well, again, I would say that that is almost like having to do awareness for abuse, adult abuse, child abuse. As adult nurses, you probably wouldn't come across pediatric patients, and yet you might well have pediatric people with the patients you're looking after. So again, it's where do you have to think, what do I need to look out for? It's not just I'm looking after my group of patients, but what else within the broader context of my communities and my social demographics do I need to be aware of that I should know? Not I shouldn't know because it's not part of my routine work, but the general conversations about things that mental health, talking about money, things we don't do that we maybe should do better.
So Tracy says it's an emotive subject, as many students will come from or have families where this is still practiced. And that you mentioned male circumcision, and it always comes up and causes further debate.
Again, it is, but that is just relevant to the Jewish religion. It's what it is. It's part of their belief system. It's part of their culture. It's part of their religion. Would I advocate for it on a health ground? Yes, on an individual basis. It's a choice, but again, men don't really get that choice because it is done as a baby. But there are medical reasons and health benefits for it still being done. It's not just that it's part of their religious ideology and has no medical benefit. As I was trying to say with FGM, there is no medical benefit for it, and there's no religious overtone that advocates that there is a need to do that.
Okay. Lindsay asks, if you're unsure of patient anatomy, how do you know to use a male or female catheter, or is there a universal catheter product you can use? Good question.
I don't know about a universal catheter product because obviously I'm no longer clinically based. But my answer would be, if you're unsure, take the smallest, longest catheter you've got. Because if it's a male, if you try and put a female catheter into a male anatomy, you're going to struggle because there will not be an awful lot left at the end, and all that's going to do is cause problem with the glands and skin damage. So if you're unsure, a longer one, and certainly if it's a temporary measure, it's not something you would necessarily have to think about long term. So take the longest, smallest catheter you've got.
And there will be local protocol as well involved, won't there?
There probably will be, and it might just be limited to what you've actually got on the shelf at the time. And unless you want to track around trying to find a size 12 or a size 10, the only thing I would say outside of that is, if you've got clear hematuria, is that you would probably want a bigger gauge catheter as a smaller gauge catheter as a starting point, because you do need to get the clots out. So
okay. Kirsty asks, hi Liz, I'm a children's nurse working as a PDN at a children's hospice and look after children and adolescents that may be born with a genital abnormality or may have neither male or female. Is there any guidance in children's urology or leading experts in this field that would support families, parents and children through counselling and psychological support, such as giving advice that's in the best interest of the child growing up?
Oh, again, then this taps into those reams of conversations that you need to have. It was for a very long time a medical decision if babies were born with ambiguous genitalia, what they were deemed to be raised as, and often had surgeries done as a baby to make it more male or more female, depending on what was on that scale. If it's more female, they would make it female, and if it's more male. These days, it's like raising children gender neutral in not giving them gender specific names and allowing them access to both traditionally male and female aspects. It is difficult. They might not know for a long time that their body is anything other than their body. And as long as they are peeing and pooing, would they necessarily know they've got a problem? The answer is no, they might not. At some point, they might become self-aware that as a young man growing up, that your urine's not coming out the end of your penis, or that your urine's coming out of your bottom of your girl if you've got the cloaca or the urethral vaginal tract. As to support, I'm sure there are loads of places out there and charities. I mean, I work in the volunteer sector, so I know full well you've only got to take a small amount of time to look for local national support groups. But again, it's that interaction between you as an individual and the patient you're looking after. And it's saying to somebody openly, I don't know, but I'm going to go and ask some questions and I'll come back to you. And as long as you come back and say, well, I tried X, Y, and Z and I'm at a bit of a loss, as opposed to you don't go back and say anything to them. Because again, that fosters that bond between you, your patient, the patient's family, the relevant authors, that you care about them as individuals, you want to try and do something. And it's that act of doing a little something, and it doesn't have to solve a problem. Sometimes it's people just want to get things off their chest. And at some point later, then, like my person with their intersex body, they'd lived for years and hadn't got to a point where they could talk about it. And even after talking to me, it wasn't an instantaneous, got to do, got to do, got to do. It was a gradual procession. So sometimes it's just taking that time. And I know that sounds very hard to say when you're clinically pressurized with no staff to cover what you've got, to take time. And it is a cost benefit that you've got to weigh up in that individual moment. Do I spend an hour and a half with my PTSD patient that is bouncing off the walls as opposed to doing 2 lots of IV drugs? No brainer. I could easily say, well, as the only qualified nurse to do IVs, that I've got to make that my priority. But do I know my patients well enough? Can they be delayed? Yes, they can. So does it matter if I don't do those IVs right this minute? No, it doesn't. Have I made that judgment? And have I committed to trying to do what's right in that moment?
Yeah.
And you can't judge that beforehand. You can't second guess yourself all the time. But it's just being that strong person and being that starting point for any conversation, even if you know you're going to feel squirmy inside, is to have that warm, relaxed, open demeanor, that you are there. And you might not have to answer a question. You might just, yeah, I hear you. Yeah, no, just carry on. You don't have to say much to be there and give that initial support for then that to be a stepping stone. And that's all this chat has been about, is to give you some stepping stones to then go elsewhere if you've got something that you need to deal with.
Yeah, beautifully put.
Next.
There's a question from William. It's question 2. Is there any guidance that would assist in the urinary catheterisation of trans person?
There are a number of ones. The RCN do one, if you look it up on the RCN website, talks about how to deal with trans individuals, trans non-binary individuals. I have probably got a number of articles on issues like that tucked away in my portfolio of things that I've researched at some point or other. But again, it's one of those that if you use any of the online searches at universities or in your place of work, or even just Google Scholar at home, you can start reading up on these things as you come across them. And it's one of those that hyperspadias, never heard of it, but went away, did a little background reading, and it was there on the back of my head. I had a physical situation that I added that knowledge to, as opposed to having a knowledge to and then a practical situation, which is sometimes the other way around. But yes, I know there are probably going to be other works out there. If you're having trouble looking them up, then please, my email is available via the Nursing Times if anybody has got a specific point that they're struggling to find information on. I'm more than happy to do that. But asking me off the top of my head to reel off things, sorry. Yeah, I might be good, but I'm not that good.
No, take your point. There's some lovely comments coming through actually from people just about we can never underestimate the importance of our interactions with our patients and making every contact count.
And that's your staff as well as your patients and significant others and families and external agency. Some of this is about the respect and time we give to each other and the dignity and the civility which we deal with each other. It's not just some of these are related to your patient base. So just remember that.
Yeah, and as Annie says earlier, a great reminder about the importance of personalised care planning.
Yes, try and make it as holistic as you can. Use that intersectionality lens as yes, I've got one problem, but do any other factors contribute to that problem? And as I said, frequent flyers, if you sort out the reason why they're coming in so often, they're not going to come in so often. And you don't do that unless you look at the bigger picture sometimes. So, yeah, good point.
And then nice one from Marwan. She says, really appreciated the human factor, Liz. And I think I would definitely second that.
That's the age-old adage that it's having something that you should know about in knowledge and penning it onto something specific. And I didn't know much about Alzheimer's until I had a study here one day, and one of the presenters had early onset dementia, and they were just so engaging as a professional, to a professional audience. It was sort of like that knowledge is now pinned on something concrete. It's not just abstract thought. It's not just that it should be there. I've got something now that marries those two together. And sometimes you get lucky and you do marry your knowledge to practice. Sometimes you never marry those two up. It's sometimes the luck of the draw, but yes, thank you. If it helps add that human element and an engaging element to a difficult topic, then I'm very grateful that I've got for you to even only one or two of you.
Well, we're very grateful. And I think on that, we're just up to the hour. So I hope I've gone through everyone's questions, if not most of them. Apologies to anyone if I've missed you out. But I just wanted to say a heartfelt thank you, Liz, for this really useful session. And thank you everyone to our audience. I hope you found this webinar valuable. Don't forget to register for the next webinar, which is focused on infection prevention and control on Wednesday, 27th of September. And you can also see any other webinars, including this one from the series, that you may have missed on demand. So thank you, everyone. Thank you, Liz, and hope to see you all again soon.
Do you want me to stay and answer any questions, Denise, or just debrief with you and Desiree and Olivia?
Yeah, I think as soon as we've finished the session, we can, I think it will cut out. But I think if people contact us and ask for any further information, we'll supply it to them.
And say I might on a roll have stuff in there that I can just pull rabbits out of hats, but not always. Clinical and stuff that I've been through, God, the amount that